Good morning, everyone. Today's lecture topic is occlusion in fixed partial denture. I'm Dr. Priyanka. So, by the end of the lecture, you'll be able to understand and outline and discuss the four types of interferences, discuss non-working interference, discuss the signs and symptoms of pathogenic occlusion, categorize the management of pathogenic occlusion. So these are also known as the learning outcomes. Coming to the introduction. So basically prosthodontics revolves around occlusion and it's one of the major topics in prosthodontics. So I'll try and simplify it as much as I can and you can read through the slides as well. So occlusion actually means closing. So there are two types of occlusion, which is mentioned here. That is static occlusion and dynamic occlusion. So static occlusion means when the jaws are closed and teeth are in contact. And dynamic occlusion is as it happens momentarily while mandible moves. So not all the states of occlusion are correct. We will be discussing that in detail in the next coming slides. So, occlusion can be defined as the act or process of closure or being closed or shut off. Also, the static relationship between incising or masticating surfaces of maxillary and mandibular teeth. So, again, you can here a note is so when there is a contact of the maxillary and mandibular teeth in functional movements, the relationship that should not be traumatic to the supporting structures or the arch. So everything in short has to be in harmony and balance. Okay, so coming to this, you can see this photo. All the red dots indicate the contact of opposing teeth. So it is basically a photo of static occlusion. So whenever we give a denture to the patient or we give a fixed prosthesis to the patient and we put articulating paper and if we put it in the whole arch and we tell the patient to bite, you will be able to appreciate all these even contacts everywhere. So these are not high points. This is just the sign of contact, proper contact of the opposite. Okay, now coming to very important three terms which has to be remembered and memorized, the definitions. So centric relation, also known as CR in short. So in short, if you talk about centric relation, it is the most retruded position of the mandible, if I want to simplify that. Okay, so we can read the definition as well. So that is the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective disc with the complex in the anterior superior position against the shapes of the articular eminences. Okay, so the position is independent of tooth contact. This position is clinically determined by the mandible as it's directed superiorly and anteriorly. Also, it is purely a rotationary movement. So, this is a definition by the GPT. Coming to the next definition, that is the maximum intercuspal position, MI, MIC, or MIP. It's referred to these short forms at many places. So, in short, that is the maximal teeth to teeth contact, which we see. So, the definition says complete intercuspation of the opposing teeth independent of condylar position, also referred to as the best fit of the teeth regardless of the condylar position. Okay, so it's the maximum contact, the intercuspation. Okay, coming to the third definition, that is the centric occlusion, also referred to as CO, the occlusion of opposing teeth when the mandible is in a centric relation. Okay, so occlusion when the mandible is in a centric relation, it has to be same as the MIC. So that is how centric occlusion is. So relationship is a state, and centric occlusion is occlusion at the centric relation. Okay, so now there are some important points to remember. In natural dentition, MI need not coincide with the CR. Okay, so the maximum intercuspal relation does not have to coincide with the centric relation in a natural teeth. However, in RPD or FPD with existing natural teeth, there can be two situations. So there can be two situations. When sufficient teeth are in contact, there can be MI which is equal or unequal to the CR. Okay, so MI and CRs, everything revolves around these two topics, these two definitions. So when there is insufficient occlusal contact existing in the previous occlusion, then the maximum intercuspation is equal to the centric relation. Okay, so in RPD and FPD, that's what we observe. In a CD case, that is a complete denture case, MI is given at CR. So we give the intercuspation at the centric relation, and that's why we take the centric relation. Okay, so that is what it says here. Okay, so you can just read through this. So I explained to you in coming to these photographs. Slide A is showing the MIC or MIP or MI. Here on the right side is the CR. So you can appreciate in this slide that you can see both the relations are falling in a different plane. The MIP and CR don't have to be same all the time in one patient. Okay, coming to the next slide. So talking about the biologic or physiologic occlusion, which is defined as the functional which is defined as a functional equilibrium which exists between all the tissues of masticatory system. So that means there is an opposing force which is balanced together. Okay, so there has to be a state of equilibrium, and also the factors are in balance. Okay, so all the stresses, all the resistance are in balance, and all the environmental factors are in balance in this occlusion. You can see it in the photo below. In an ideal occlusion, so this is an occlusion in which maximum intercuspal contacts are there, in which it provides efficient mastication and aesthetics. Okay, so in short, that is what it is. So in ideal occlusion, mastication and aesthetics have to be balanced out, okay, and has to have a maximum intercuspal contacts between the upper and the lower arch. Okay, so certain characteristics are there in this. So these characters are it has to have a stable posterior contact. The MIP coincides with the CR, and no posterior contact in eccentric mandibular movement. So we'll be discussing that later. The working and the non-working sides. Then there is contact in the anterior teeth and harmony with the jaw movements. Okay, and the occlusion should be in angles class 1. So those were the ideal occlusion. So now the importance of ideal occlusion. So it can be used in diagnostic casts, examinations. Okay, as stated in this one. It can be used in correcting the TMDs and occlusal interferences if they exist before any of the restorative procedures, for final prosthetic rehabilitation. So in the final stages, okay? Coming to optimum occlusion. So in an ideal occlusal arrangement, the load exerted uh, should be distributed optimally. Okay, so occlusal contact has been shown to influence muscle activity during mastication. So there are a few effects which I will just talk about. That is a direct effect. So in short, any high points in a restoration or occlusion hampers the muscles of mastication. We should not have any high points which affects any of the muscles. So the horizontal forces should be minimized and avoided. So we should have a proper centric relation and we should have a proper cusp and fossa relations. Okay, and so there should be a proper cusp to cusp contact. A chewing and grinding is enhanced, and that's how the chewing and grinding will be enhanced. And this is best achieved by giving mutually protected occlusion. That is this occlusion scheme, which we'll be discussing. Okay, so concept of occlusion, there are three concepts. That is the bilateral balanced occlusion, unilateral balanced occlusion, and mutually protected occlusion. Coming to the balanced occlusion, so here all teeth are in bilateral contact in anterior and posterior occlusal areas in centric and eccentric positions. Okay, so that is what the definition says. All the sides, both the jaws, the anterior and the posterior teeth, have to be in contact in any position. Okay, so in natural teeth, the balancing side contacts are inappropriate. Okay, so balancing side is the one which we move the jaw towards. So and potentially harmful as they constitute. So if balancing side contacts are inappropriate, they lead to premature contacts, and that might create problem with the PDL, the TMJ disturbances, and occlusal wear. Okay, so coming to the canine protected occlusion and mutually protected occlusion. So according to JPD 2017, it's defined as the mutually protected occlusion is defined as occlusal scheme in which the posterior teeth prevent excursive, excursive contact of anterior teeth in maximal intercuspal position, and anterior teeth disengage the posterior teeth in the mandible excursive movements. So when the posterior teeth prevents any excessive contact of the anterior teeth, when it's properly into an intercuspal position, and when the anterior teeth disengage the posterior teeth in any of the side to side, lateral, or eccentric movements, that is what is known as the mutually protected occlusion. Now coming to the GPT definition of canine protected occlusion. So this is mutually protected occlusion in which vertical and horizontal overlap of the canine teeth disengage the posterior teeth in excursive movements of the mandible. So when we move the teeth side to side, and that is um, if the canine guides our movement, then you can see that if the canine is only the one touching, then you can see and appreciate that it is a canine protected occlusion. Okay, coming to the next slide, that is the features of mutually protected occlusion. So there are certain features. Okay, so that you have to have a uniform contact between all the teeth. There should be stable posterior tooth contact in all with all the forces. Centric relation should coincide with the MI. No contact with posterior teeth in any lateral or protrusive movements. Anterior teeth contact in normal relation. Yeah, and then these are the criterias for the same. They would only be contact in harmonious relationship in a full complement of teeth exist if the whole teeth set is present. The supporting tissues are healthy. There's no crossbite and in angles. Okay. So this slide basically says so anterior and posterior teeth should be in occlusion. The posterior teeth have stops. Okay, have stops, and when the maximum intercuspal position happens, so these serve as stops. Okay, so disadvantage of that is if it was not there, it would weaken the periodontal ligament of the anterior teeth. It is also not there in case of missing canines, class 2 and class 3 situations, and crossbite situations. Okay. Okay, so now coming to the working side and the non-working side. So basically the working side is where the mandible moves. Okay, non-working side is the opposite side. Okay, so the canine guided working movement, the premolar and the molar on the working side become separated as the mandible moves away from the centric occlusion. And in non-working side, it becomes separated as the mandible moves away from the centric occlusion. So working side is the side where the movement occurs, okay? And the opposite side is the non-working side. Okay, coming to the unilateral balanced occlusion, that is also known as the group function. Okay, so here the exclusive contact means moving away from the MIP position, which occurs on the working side. Okay, so that's basically the definition. So the definition says multiple contact relations between maxillary and mandibular teeth in lateral movements on the working side, whereas simultaneous contact on several teeth act as a group to distribute occlusal forces. So when a group of teeth function together, it is known as a group function. Okay, so on the non-working side, no contact happens till the centric relation in the mandible. Okay, and there should be a normal intercuspal relationship. Okay, so that's what the slide says. You can also read the slide. Okay, so the occlusal load is equally distributed in the PDL of the teeth on working side. So Uh, so advantageous if, for instance, the PDL support of the canine is compromised. So while on the working side, occlusal load on excursion happens. On the non-working side, the posterior teeth do not contact. Okay, so on the working side there is a occlusal load force because we are doing the excursive movement, and on the non-working side the posterior teeth has no contact. So that is how the working and non-working side works. Okay, coming to long centric or freedom of centric, that's what it's known as. So in short, what it is to close in between, to occlude in between the centric relation and centric occlusion is known as the long centric. So that is freedom of centric. Okay, it's not freedom in centric. Okay, so coming to the definition, when centric relation and centric occlusion do not coincide, a, a freedom is given to close the mandible either into centric relation or slightly anterior to its centric occlusion, with a smooth gliding without affecting and change in vertical dimension of occlusion. Okay, so this concept has evolved and finally known as the long centric. Okay, because of the freedom of movement. Few important points to remember is long centric involves primarily the anterior teeth, and long centric refers to freedom from centric, not in centric. Okay, coming to the occlusal interferences. So these are the undesirable occlusal contacts which occur, and it may lead to pathologic occlusion. Okay, so it has to be assessed, corrected with the help of mounting the diagnostic cast before prosthetic rehab procedure, and then we can, uh, okay. So response to occlusal interferences, there can be a lot of characteristics, that is toothache, tooth tender on biting, tooth wear, spastic masticatory muscle, which is also known as HMS, that is masticatory spasm, which is a rare movement disorder of the muscle. Okay, that can also happen muscle tension, headache, condyle derangements, degenerative arthritic changes in the TMJ. Okay, coming to four type of interferences, which are centric interference, working interference, non-working interference, and protrusive interference. So we'll be looking at centric first. So centric interference is when mandible closes in certain way if in case the force is prematurely contacted. So in the case of premature contacts, the mandible will close in a certain way. Okay, so there should be no premature contacts or interferences which exist. That's when, if they exist, that's when centric interference happens. Working interference, so contact of maxillary mandibular teeth on working side occurs when anterior disoccludes. Okay, so when anterior disoccludes, you can see that there is a contact point which is established. Okay, that is known as a working interference. This should ideally not contact. Non-working side interferences, so that contact between maxillary and mandibular teeth and lateral excursions. Okay, so you can see that in the photograph, this is the working side and this is the not working side. So when the mandible moves to the left side, this region becomes the working side and the opposite becomes the non-working side, and ideally none should be in contact, right? If any of these are in contact, it becomes interference. Okay, coming to the protrusive interference. So when distal of the maxillary posterior teeth contact the mesial inclines of mandibular posterior teeth, it leads to pathologic occlusion. So these are destructive forces due to maybe closeness of teeth to muscles, non-axial nature of forces, inability of patients to incise. Okay, so when these forces contact tightly, they create problems in the tooth structure and the PDL structure. Okay, in the protrusive movements. That is what the photo is showing. Okay. Again, it can be corrected, assessed with the aid of mounted diagnostic cast before prosthetic rehabilitation is started. Okay, coming to pathogenic occlusion. Pathogenic occlusion is defined as occlusion relationship capable of producing pathologic changes in the stomatognathtic system. Okay, so that means if it produces problems and our whole system, the TMJ, the muscles and the teeth, everything is affected, then it will be a pathogenic occlusion. In such occlusions, sufficient disharmony exists between the teeth and the TMJ to result in symptom that involves intervention. So you understand, if we are creating problem in our whole system, the stomatognathtic system, then there has to be a pathogenic occlusion, which needs to be corrected. So there are certain signs and symptoms. So in the teeth, there can be mobility, open contact, any abnormal wear, fracture, chipping off. In the periodontium, there can be chronic periodontal disease, widening of the PDL, and any tooth movement, compromised crown to root ratios, widening of the PDL. Okay, so coming to the TFO. TFO is the trauma from occlusion. So it is an injury to the PDL from the occlusal forces, basically. That's what it means. So it leads to mobility, and also it is tender on percussion. Okay, so you can see that there is widening of the PDL here. Okay. So on the musculature, there can be chronic fatigue, spasm, pain, restricted movement, trismus, and myositis. Okay, and in TMJ, there can be pain, clicking, popping of the TMJ. Okay, coming to the pathogenic occlusion treatments. Okay, so in short, it can be divided into short-term and definitive treatments. In short term, basically we give occlusal splints. In long term, we basically give orthodontic treatment. Okay, so we'll just read through this. So in short term, you give an occlusal splint or device. So it is used to serve to deprogram the occlusion, such as that of future restoration and centrangulation, and is easily accomplished. It acts as a diagnostic tool in determining if the proposed change of occlusal scheme will be tolerated by the patient, and it can relieve the myofascial pain. Okay, in definitive treatment, the orthodontic treatment is used to correct the malalignment. Okay, so it can be treated. Okay, any of the replacement of the missing teeth should be done, and any of the grinding should be done if required. The photo shows an occlusal splint. Okay, in occlusion, the short term. Okay, so coming to the examination of occlusion, so how do we do that? We use an articulating paper, and we mark the static occlusion when the jaw is in a closed or when the jaw is closely in contact. We will tell the patient, we will put the articulating paper on both the sides and one by one, and we will tell the patient to do lateral movements, protrusive movements, grinding, chewing, and swallowing. So when the patient does lateral movements or side to side movements, you will be able to see a blue mark on the teeth. That is the dynamic occlusion. So the dynamic occlusion will be marked. So the dynamic occlusion, if you remember, is the momentary contact during the movement, which is done in the lateral excursions. However, when the patient closes the jaw properly, you will be able to see the red marks, and those will be denoted by the static occlusion. So we'll tell the patient to open and close. We use the Miller forceps to hold the articulating paper in place. So one side there is a blue marking and the other side there is a red marking. Okay, so that is what it is in short. So coming to the points to remember. So there has to be a proper cusp and fossa relationship. The supporting cusp, uh, in supporting cusp, what has to come in contact is the mandibular buccal and maxillary palatal cusp. So both of these cusp have to come in contact in the supporting cusp system. In the non-supporting cusp, that is the guiding cusp, which are not in contact, so those should be mandibular, lingual, and maxillary buccal cusp. Okay, so we have to remember that in the fabrication of any of the prostheses, and if we keep these things in mind, the supporting cusp and the non-supporting cusp, the fabrication can be made better, and we can get rid of any of the occlusal interferences which are present. Okay, so thank you so much for patient hearing, and you can refer to two textbooks of fixed prosthodontics, that is Rosenstiel and Schillenberg, and you can find me around and have a word with me if you have questions regarding this topic. Thank you.